This is Mary Starks. I'm the Marketing Manager for Wolters Kluwer. I'd like to welcome you to today's webinar, the Grade 8, a deep dive into SNF PPS Final Rule. Let me go over some quick instructions before we get started on how to use the system. If you have any questions, please use the Q&A menu bar located on the GoToWebinar menu on the right side of your screen to submit questions, as all your lines have been placed on mute. There are handouts today, and you can download a copy of today's presentation by selecting the handouts on the GoToWebinar toolbar and following the instructions. These handouts will also be sent with an automated follow-up to the webinar that will happen, that will also contain a full replay of the webinar. Today's webinar is pending for 2 hours of continuing education units from AHEMA, and an email with that survey and download instructions will be sent within 1 to 2 business days of the webinar. I do want to warn everyone that both AHEMA and AEPC are very backed up in approving both CEU applications and in processing CEUs, so there may be a delay, but we did apply for them and have been given pending approval, but we don't have a final application in hand yet. With that out of the way, I'm extremely pleased to welcome back Chris Mastrangelo, the President and CEO of Harmony Healthcare International. Chris's leadership and vision have helped Harmony Healthcare become one of the most recognized and trusted consulting companies for compliance and reimbursement in the healthcare industry. Chris brings her post-acute care expertise with more than 20+ years experience in this industry as an occupational therapist and licensed nursing home administrator, and she holds a master's in business administration. Chris?
Thank you so much. Thank you to Wolters Kluwer for inviting us to speak today. We're very grateful for our partnership. And thank you for the hundreds and hundreds of people that are on this webinar. It's amazing. The final rule is fascinating, and there are ample slides, and I will tell you up front that I will not go through every slide. In true Chris fashion, I always feel compelled to give you ample information and to walk away with nuggets. The actual final rule came out at the end of July, and then it was really publicly promoted in the first week of August. It is, I think it is about 340 pages, and the goal of this webinar is to give you the nuggets, but what we like to do is to distill and synthesize the information, and which affords you the ability to apply it in your organization and not have to go through the hours and hours of reading that we do. So that's Chris, that's me, and she mentioned our organization is a consulting firm, and thank you very much, and I do see that a lot of our customers are on the call too. So what are we going to learn today? We are going to identify some key elements of the final rule. We want you to be aware of the calculation for value-based purchasing. We actually made t-shirts of this calculation. Identify that the SNF QRP quality reporting, okay, measures which were derived from the Impact Act, and pretty much your reporting timelines for information that you need to submit to the government. So a lot of learning objectives for a 45-minute webinar, but we're going to get there. So every year the government comes out with what they call the final rule, and the final rule, the intent of it is to inform skilled nursing facilities about the rate increase that goes into effect every October 1st. So for those of you that might be new to long-term care or the skilled nursing facility arena, their fiscal year is October 1st through September 30th. And the government will assess the amount of resources and dollars that will be infiltrated into your rates, specifically your RUG rates, for the following year. Within this document, they will and can speak on other subject matters, but the primary objective is your reimbursement. Again, the reason I bring this up is because of the recent 700-page requirements of participation. While they're from the same source, they have a different intent. The final rule is about reimbursement, about the reform, and things of that nature. So in the objectives of the final rule, number one were payment rates, and we'll get to that slide as well, but number two, they're going to talk about your value-based purchasing metric, which is hospital readmissions, and potentially preventable, which will be the evolution of that. It will elaborate on your skilled nursing facility VBF, value-based purchasing, and I'll teach you that as well. And as we said, your policies and measures for your QRP, your quality reporting program. The essence of your quality reporting program is the data that is required for your value-based purchasing, but value-based purchasing only allows one metric to be introduced at a time for monetary purposes. So let me just say that again. Quality reporting program number 4 may not have a direct relationship to your payment yet, because number 3, value-based purchasing, you only can have one metric at a time. Again, I'm going to go over that again, but I want to give you the essence of it. Okay. Other areas in the final rule are the 4 new quality and measures, and really to talk about that, your data will be publicly reported and transparent to the community, your consumer. So the essence of value-based purchasing in the Impact Act talks about a measurement, a report, and a reward, which is in a subsequent slide. But let me say this one more time. There's a measurement, that is your hospital readmissions. There is a reward, which is your 2%, and there's a report. And that report, for all intents and purposes, is your 5-star, okay? But that report, for now, is going to be confidential and only sent to you until it becomes public. So, but we'll get there. That's an overview. Don't stress over that. The other piece that one needs to be aware of, when you have skilled nursing facilities across the country, you have different rates. And the reason you have different rates is because of your wage index. It may cost more to have a nurse in Cape Cod, Massachusetts versus Nashville, Tennessee. So your rates differ based on the component of the wage index. And this has been a long disputed discussion because the data is typically or has historically been acquired from hospital wages, but near here or there, the fact of the matter is that your rates are contingent upon your wage index. Okay, so there's another word that you will hear called market basket. And for those that are obviously not fiscally, savvy, all it means is the cost of living. And, the essence of it is they look around and they say, okay, we're going to give the skilled nursing facility a 2.4% increase. Now, there's more of a gyration that goes through this calculation, but the end game is, are we getting an increase, are we getting a decrease, are we getting nothing? Some years they will they will decrease the rates because they felt that prior years they've overpaid, but this year is a good year and it will be a 2.4% increase. So fiscal year 2017, slide 9, again reminding those that the fiscal year is October 1st through September 30th. So you are seeing that the average increase is 2.4%, but the second bullet on slide 10 says, you know what? Some other areas might have a higher increase of 3.2%, while urban New England areas have the smallest estimated increase of 1.6%. Very good. So again, nuggets, distill, synthesize. Just last night I was on the phone with one of our Harmony Healthcare specialists, and she's in a building, and she's like, I think they've got AIDS patients and they're not coding them. Take pause, go back into your building. This is one of the biggest nuggets you can have. If a patient is coded an 042 on Medicare Part A, there is a different payment level, and it's a 128% increase. So if they were an HC2 at 438, you could, in essence, be at $998. The government estimates about 5,000 patients who qualify. Take pause. If you get one thing out of this, go back and assess your buildings to see if you have any AIDS patients that are on Part A that would get this higher rate. Okay. So I am going to go ahead. No, I'm going to go back. I was going to tell you something about VBF, but we'll go there. Now, slide 14. This to me is so significant by virtue of the fact that I came into long-term care, when it was cost-based, and I saw the evolution to PPS. And I treated as an OT 7 days a week, understood the value of outcomes and patient care, etc. Please be mindful of what I have dubbed RUGS intimacy. The government, when you have a RUGS score and you qualify appropriately into an upper RUG level, they have a term called presumption of coverage, meaning that by virtue of your RUG score, you are automatically deemed skilled up to and including the assessment reference date. You might sit back and say, well, what does that mean? Oh, that's so obvious. Well, what if you have 10 medical reviews? And those 10 medical reviews are looking at newly admitted patients, and they're accurately coded, and they deny them, which happens all the time. So we write prep letters for our clients, and we will say, by virtue of the presumption of coverage criteria, they automatically are skilled from days 1 through 8, and there is no contest here. So the other reason I bring this up to you is because the nurses on the call, we know that nurses rule the world. I'm an OT. Because OT, PT, and speech come and go. The patient is there 24 hours a day. So, and again, this is something I've preached for years, but I've found that in my recent tour that some things get forgotten or diluted. The nurses need to anchor the patient. When you complete an MDS, there is a RUG score for Medicare Part A. There is also a backup score for Medicaid or what have you. The nurse should know that backup score, and her or his documentation should have what I call RUGS intimacy. And they need to identify, for example, if it's an HE2 and they have respiratory therapy, why are they in that RUG level? That's where the connection of the dots occurs. So presumption of coverage is telling you as a provider that the RUG level has influence over your ultimate payment and justification for your payment. By the same token, a lower 14 is an area that as we go in and we look at all of our lower 14s, and you'll see more of them with the advent of a COT, the change of therapy, the lower 14 is a trigger, an audit trigger for, were there enough therapists? Are they doing COTs properly? Are they doing them too frequently? Do they have a staffing issue? So because the government perceives a lower 14 as possibly not qualifying for skilled services. So the fact that this terminology was brought up during the final rule of this year, I think it's very powerful, and I think you need to run with it and go back and be sure that everyone in the building understands the non-rehab RUG level. Nationally, 9 out of 10 patients fall into a rehab category, right? So 90%. So it's very easy for nursing to, therapy is the anchor. Never in my career have I seen a patient that would be skilled only by therapy. Nursing is there 24 hours. I'm giving you a nugget to look at the correlation between the non-therapy RUG score and the nursing documentation. Very good. Okay. Oh, and I did this particular slide already. Obviously monitoring for changes in the patient and the services are reasonable and necessary and RUG's intimacy. You have to go back to basics. You have to understand what skilled services are. Regardless of value-based purchasing or whatever insurance or payment reform comes our way, the traditional Medicare that was created has rules, and those rules need to be followed by traditional and managed Medicare programs, and that's a whole nother discussion. This slide is elaborating or depicting that there's a lot of confusion in the industry. If I sleep 2 hours a night, and that's what I sincerely do, to keep up with everything changing, it has to be clear as mud at the facility level. There are 43 quality measures, of which 16 depict are reflected on your 5-star. When we talk about QRP, when we talk about quality measures, they originate from all over. There are so many initiatives going on that they overlap, and there might be a hospital readmission, and it may be calculated one way for QRP and another way for 5-star. So what I'm saying to you is just breathe and understand that you just have to take away the points that you need to know today and chunk it. Okay. Value-based purchasing. I'm skipping ahead and I'll go back. I'm going to say this. There's a measurement, there's a report, and a reward. This is not written in the final rule. This is me taking the extra step to say to you, wait a minute, what is value-based purchasing and why are they doing this? The concept is that they're going to pick a measurement to gauge the success of the care provider. The measurement is all in sync, hospital readmissions. I could stand in front of 300 people and ask the question, and no one would know the answer. So if you didn't know the answer, don't be ashamed, because there's clutter. We have too much clutter in our brains. The report, well, really, it's on your keys system, right? It's a claims-based report. It's coming to you privately, but it'll ultimately be on your 5-star. And the reward is 2%. Now, follow me. That reward will take effect October 1st, 2018. That is fiscal year 2019. At the beginning of the fiscal year, if you meet the metric, you get your 2%, 2% of total revenue. So in other words, it's not an addition to, it's almost a take back, and we'll give it to you if you meet the metric, which I haven't given you the metric yet. So a measurement, a report, and a reward. Now, so now I go to here. The measurement is all-cause hospital readmissions. Now, they want, why? Readmissions happen irregularly, well, regularly, but without, you know, maybe medical necessity. You could have a certain doctor that just readily readmits them, a certain nurse, and the studies have proven that A, it's costly, but B, it really isn't good to readmit patients on a regular basis, secondary to it's a new environment, it's a medication regimen that might be changed if they have some cognitive issues, it's a new environment, so it's in everyone's best interest to not readmit a patient unless 100% necessary. And so your nugget is that and this is in a slide, so don't freak out, you will need to track your data and analyze it, because you have to figure out whether you're going to get the 2% or not, and you need to drill down on, if you're above a certain level, why. Let me give you an example. So I'm a data freak, and I always have been because I'm a daughter of a mathematician. So I've collected what I call CAF, clinically anticipated stay, for 15 years that Harmony's been in existence. And a lot of people say, well, why do you do that? Because I love the data. But a great example, true story, 8 years ago, a CFO calls me up and says, Mr. Angelo, why is my census plummeted at this facility of the 19 that I own? And I whip out my report and I say, my length of stay, i.e. CAS report, states that you had 7 discharges Saturday after 3. Go there with me, right? In other words, but if I didn't have that data, we don't know why the census plummeted. Could it be that the admissions person wasn't doing their job? Could it be that the facility has a poor reputation? This data is so powerful because we know that they're going out the back door. Now we just need to QAPI or CQI why on Saturday after 3 they all tend to be discharged to the hospital. Was it a nurse? Was it a doctor? And therefore your energies are not being expended in unnecessary rabbit holes. So back to all-cause hospital readmissions. All-cause is the key word because that will change. Now, it'll be effective October 1st. We already did that, which is slide 19. And we're going to go through this. We did this, report, reward. Oh, but let me go back for 1 second. Report. To reiterate, in the methodology of value-based purchasing, transparency is critical. You see, whatever the metric is, whatever the measurement is, the government wants the consumer to be able to track that metric and compare and contrast you to all the other providers, and they can then therefore make informed decisions. So, okay, so this part is really important. This is a nugget, so this is where you write things down. They're going to determine if you receive the 2% one of two ways. Did you improve, or how did you rank? So let me say that again. The base year is today, this year. They're comparing you to your base year was 2015, which was last year, so there's nothing you can do about it, but they're comparing you to 2017. So from 2015 to 2017, if your data improves a lot, then guess what? You will qualify for the 2%. But let's just say you didn't do so hot because you're really, really good. The other way they will calculate if you get the 2%, so it's either or, is how you rank. So for those of you that analyze your PEPR, our customers, we analyze them every month, and it's all about ranking. How do I compare to the other 16,000 SNFs across the country? And it's all about percentile ranking, if you're in the 80th or the 20th percentile. So the government is hot to trot on comparing and contrasting. So in 2017, if you were really, really good in 2015, and you are really, really good in 2017 and you're up there ranking, you're better than 8 out of 10 nursing facilities, you will then get your 2%. So again, conceptually, I want you to understand how they are determining your hospital readmission rate. And by the way, the current national average is 21.1%. So if you're tracking your data right now and you know that your hospital readmissions is lower or above, it's going to give you a good gauge. So we anticipate that if you're under a 20%, you will most likely get your 2%. That doesn't mean you should stop and not pay attention. This task of analyzing your hospital readmission data, and let me back up, all of your data will play into your facility-wide assessment, your competencies, and your QAPI and your CQI. So it's a multifaceted benefit to hone in on this data. Okay? So the key thing with value-based purchasing is that they can only introduce one metric at a time. I'm still trying to get clarification from CMS on this. So therefore, while they are focusing on all-cause hospital readmissions, they are ultimately going to change it to potentially preventable readmissions. So let me go to, I'm going to skip over that because I want to give you the, they're going to potentially change it to a more stricter calculation. In other words, all-cause readmission means every single patient that goes back to the hospital. But if it goes to potentially preventable, that means that, well, wait a minute, they should not have gone. What did you do? Now, the nugget here is that the government cannot proclaim a metric for value-based purchasing without giving you 61 days notice. That is a point of contention for most providers. How can they gear up for something that they don't know? Now, typically, what we anticipate is that every year when the Federal Register comes out with the final rule, they will define the metric, the measurement. So, but just so you understand, all-cause readmissions could rapidly convert to potentially preventable readmissions. So I just want to make that clear. Either way, you should be analyzing your data today in order to positively impact it for January throughout the year. So therefore, it's today's job is tomorrow's success. Today's work is tomorrow's rewards. And interestingly enough, the government is not doing a snapshot. They're legitimately taking 12 months worth of data. So here you go now. You've got to totally get a handle on this information. Okay, so now I'm flipping around the slides. Don't worry about that. When it talks about all-cause readmission measure, it's going to give you some more definitions for this. And it's basically if they're in your building and they're under a fee-for-service, traditional Medicare Part A, and they leave, and if they are back to the hospital within 30 days of a discharge from coming into your building, okay, so they leave your building and then they go somewhere after they leave, guess what? It's part of the calculation. So some areas like Ohio and other parts of the country are implementing, clinical navigators. So meaning they leave your building, and who is monitoring that patient's success? Now you may, they left my building, I have no concern, but there is clearly an incentive for you to call and have what's going on, how are you doing? Now, another nugget for you is, let's just say they go home for 2 weeks and they have a raised temperature, maybe it's a suspected pneumonia. Remember your traditional Medicare rules. Within 30 days of leaving your facility, if they have Medicare Part A days left, they can come back, right, and access their Medicare Part A benefits without going to the acute care. Interestingly enough, last night I was fine-tuning a blog on the OIG 2016 report, the Office of Inspector General, and one of their 7 areas of focus happens to be the 30-day readmission. In other words, when they don't need to have the stay. So I'm thinking it's intriguing that they're focusing on this metric, and I also feel as though many providers forget about this benefit, and I'm even speaking to patients that are within your organization that may go to another unit or they're long-term care, and wait a minute, 2 weeks ago they became ill and you didn't realize you could put them back on Medicare Part A. So typically we recommend during your Medicare meeting to always review patients that have been taken off Medicare Part A within the 30 days. So you can simply implement that for the patients that are discharged to home. Again, I'm sure there's a lot of different systems out there, and again, I think it's a phenomenal nugget. When we talk about quality measures, when we talk about quality reporting, there are different origins. Hospital readmissions is claims-based, so that means it is coming not from your MDS, but from your UB04, okay? It's coming from your working file system. It's not a clinical data entry piece. And as of today, you should be receiving your readmission data at your facility through your KEYS system, and only administrators and certain people have access to this. So you should be taking a look at that data and working on it. So this is other slides that, that give you the bullets of the calculation and the rules and all that. But I have to talk to you about the calculation because it's fascinating. And let me go here. See this slide 43? If you're a math person, and I say to you that 21% of your patients are being readmitted to the hospital, you're like, oh, wow. The government said, ooh, it's too difficult to understand, so we're going to invert it. And because people have the logic that higher is better, okay? So they take your the national 21%, and they take, it's called the inverted rate, 1 minus, again, 0.8581, and, 0.14, and then it equals 85 or 86%. Really, I'm not asking you to learn the calculation. I'm simply stating that they changed the calculation so it's more in alignment with our brains. But let me go to, this is the actual calculation, and we sort of chuckle at Harmony Healthcare because we put this on the back of our T-shirts. It's like the Big Bang Theory, you know. I mean, we love math, but that's how they're going to determine your SNF achievement score. Now, let me go through with you by just looking simply at the slide. Up top it says SNF achievement, but on the top it says performance. So again, your ranking versus your improvement. So there's two methodologies to see if you are going to get that 2% or not. Again, that's just narrative on the calculation. Have at it if you want to look at that. The concepts are there, and the deadlines are there and all of that. What do you need to know? 2015 is your base year, comparing to 2017. What do you need to do? Get off the phone, analyze your data, copy it, and see what's going on, and see if you can have an impact on your performance. So when I mentioned keys, it sounds like keys that are gold and open a door, but it really is on slide 52, QIES, Quality Improvement and Evaluation System. That's within your building, and you can obtain a ton of reports out of this system. When we go into our buildings, we print those out and we analyze that data. So, okay, so I'm going to go into this particular area here. I've already mentioned it, but you need to know that the measurement for value-based purchasing could evolve to potentially preventable. And this is going to be, how do I say this, more controversial because they have to define what is potentially preventable. And that's really what I'll say about that until we get the information. Of course, there are a lot of PACs, MACs, entities that have philosophical disagreements with value-based purchasing. We are pretty objective, and you know, we want to share the information with you, and there are pros and cons to every system, but what you're learning in value-based purchasing in SNFs mimics what occurred in acute care within the last 10 years, and their value-based purchasing, one of their metrics is customer satisfaction surveys, and if they do not receive a 90% approval rating, then they have a take back, or excuse me, a monetary negative. You know, they don't have their money. So again, I want you to be aware of this concept of value-based purchasing and how it's going to affect you. So again, there's more discussion on the preventable, unplanned, hospital admissions. They came up with 4 rationale groupings. You know, chronic conditions, infections, unplanned events, and injury prevention. And coupled with the conditions of participation, which the responsibility is being shouldered by the skilled nursing facility, this plays right into that. In other words, your quality measures, the 16 quality measures that you focus on, have a direct relationship to care, cost, and consumer satisfaction. So if you talk about infections, for example, it's a hot to trot. The government's hot to trot on infections by virtue of the fact that unnecessary infections can be preventable with proper hand washing, with glove usage, with protocols, with policy. So I think that the culture within your organization has to evaluate, you know, how can we do better? And as I talk about the gold standard in the Ritz-Carlton, it's always refining what you do. It's never finger pointing. It's, okay, we did it this way, but how could we be better? And I think that's the essence of the program. So, okay, so there's a lot to cover, so I'm going to skip through some of these things. And this particular, you know, again, words you can read later. I've got about 10 minutes, and I just want to make sure I get through everything. You are evaluating, again, hospital readmissions. So I'm not going to go through that. There's links for you. The word risk adjustment is fascinating, and meaning that it's leveling up. The correlation is if you golf, and you go to a golf tournament and they say, what is your handicap? Meaning, I shoot this, and then everyone starts golf on the same playing field. that is what a risk adjustment is. So they take into considerations other facets about that patient's diagnosis and medical history, not to negatively penalize a healthcare organization by virtue of their pre-existing condition per se. So that's where a risk adjustment comes in. So again, the base here is this. Now we're going to jump to SNF quality reporting. And what I'm saying to you is that this is not necessarily related to your monetary impact. These are measurements that the government is monitoring to see how well you care for the patients. I do not know if they will ultimately have a direct relationship. So the three new quality measures are the patient who experiences one or more falls with major injury, 2, pressure ulcers that are new or worsened, 3, skilled patients with an admission and discharge, and this is where you're completing section GG, which we're going to have a conversation about. And these have been rolled out, and I will tell you that falls with major injury, number 1, the biggest thing that you need to know with your staff is what is a major injury. So don't assume that, how do I say this, as a AAA quadruple perfectionist and a quadruple Capricorn, you know, with my planet, sun, and everything in Capricorn, we want to do the right thing. You want to do the right thing. The MDS has 1,000 points of information, okay, of which 108 elements depict one of 66 RUG categories. There is no perfect medical record, and there is no perfect MDS, period, end of story. As much as we want it, it's not going to be there for a whole host of reasons. It's dynamic, the patient changes, the staff changes, it's a very complex world. However, if I can give you the nugget, or I call it the key word, in this particular metric, falls with major injury, be sure that the person coding it knows that a major injury includes bone fractures, joint dislocations, closed head injuries with altered consciousness, and a subdermal hematoma, and this is in your MDS REI manual, okay? Now, pressure ulcers. Well, extremely complicated area to get into by virtue of the fact that you and I both know that skilled nursing facilities provide some of the best care and prevent pressure ulcers because it's a skill set. It's a skill set to treat and observe the senior patient population. So as you can see, new or worsened, and it's a short stay measure, so be mindful of this. If you did not code it correctly on your first MDS, your subsequent MDS may look like it's new or worsened. More often than not, this metric comes into play because of improper coding. And it gets complicated because the person completing the MDS is not necessarily a wound care specialist. And the MDS reverse codes. And then you have your wound care specialist coming in only on Wednesdays. So again, with the essence of this quality reporting program, go back and say, wait a minute, am I back to basics? Am I simply coding it, capturing it the correct way? And number 3, section GG, well, that is a whole discussion in my world. And this section GG has rules, and your MDS coordinators need to have 100% training on this and 100% audit on this, because the coding of it could make or break your performance, and you know, versus lines, and there's a major discrepancy in it. I will give you that example. The ruling, and just last night I sent an email out to my team on this. Section GG is the essence of it is that, hey, you know what? If you go from the LTAC to the nursing home to the home care, the government wants to see outcomes and improvement. But historically, that data is extremely difficult to collect because we use different evaluation tools. So for example, skilled nursing facilities use the MDS, home care uses the OASIS, and the inpatient rehab uses the IRF-PI. So let me give you a different, so if I am an OT and I work, I'm going to give you another analogy. I work in the rehab hospital, and then they ask me to go to the acute care to do an eval because it's connected by a hallway and they're understaffed. I, the OT, look at this eval to score or assess a patient who had a stroke 3 days ago, but their tool is totally different than I'm accustomed to. It's one page, it's like Modicist, Maxicist, but over at the LTAC we use the FIM. Well, you can't have what I call same store in business. Is it oranges and apples, or is it oranges? So the government, through the Impact Act signed by Obama in September of 2014, mandated that there is a universal documentation. That being said, that is section GG. Very good. Now, your goal is to make sure that section GG is being completed correctly and efficiently and accurately, because it is fundamentally, how do I say this, confusing, because the numeric system is opposite of section G. Easily someone could miscode it simply by the 1 through 7 or 1 through 8 is the reverse of section G versus GG. Number 2, they have to put goals in, and they have to establish goals, and they have to use the evaluation period within the first 3 days of admission, and the first segment was prior to therapy intervention. Now, I just read a clarification from CMS that says it's okay if therapy treats, so why even put that in there? The point of this nugget, or this number 3, is that it is top on your list, because if you are incorrectly filling this section out, then you are at risk of losing dollars and part of your value, ultimately your value-based purchasing. Okay. Again, well, let me give you an example. If you fill it out incorrectly, we said that's slide 77. What will happen if you do not report? If you put dashes and do not put in the goals, it is considered not contributing your data, and therefore you will have a negative payment adjustment in 2018. Very good, very good. Okay. So other areas, again, 340 pages we're doing in 45 minutes. It's very exciting. Another quality measure is this medication reconciliation. Conceptually, I need you to work with me here. I take 5 medications, but you know what, my orders are for 5, every day, but one of them I take every other day, one of them I cut in half because I travel, and what, I can only refill them in certain days, so I'm going to squirrel them, and then I fall and I fracture my hip, and I go to the hospital, they look at my medication regimen, and they put me on what they thought I was on before I came in. Now I'm snowed because I really never was on that. Now they have to do an ORIF, they give me some Levaquin and some pain meds and all these other areas. Then I go to your nursing home. Well, it's all about the drug regimen and the reconciliation. What is the patient on? What are they really on? What am I giving them? And what are the contraindications from those medications? And again, there's going to take resources from the pharmacy, but the facilities need to be mindful that they're going to be responsible for this follow-through of medication administration. You see, more deaths occur from contraindications of medications than natural causes. So someone needs to say, wait a minute, you can't be taking that drug with that drug because it's explosive. And I think that there's a huge focus on this, and the pharmacy companies are aware of it, and it's about bringing the resources in and looking at that drug regimen. Okay, so I'm going to, again, I do speak over the slides because the slides are there for you to read later. I think anecdotal concepts are better for you to take away, and there's just a lot of information in there. And okay, so what are the new adopted quality measures? This is now for your quality reporting program. So they're going to look at your Medicare spending, they're going to look at your discharge to the community, and then your potentially preventable 30-day post-discharge readmissions. So when you think about, oh, wait a minute, I'm going to be penalized if a patient comes to me and then is readmitted to the hospital, so I need to focus on that. But then I'm also going to have to, sorry, I'll go back, don't worry. I have to focus on, wait a minute, they've been with me, and now I send them to the community, and they go back to the hospital, right? So I'm sitting there going, it's not just a readmission from the SNF bed. If they go home and return, you are going to be responsible and monitored for that as well. So, and that's where we talked about this already, but we had that risk-adjusted area. Let me go back to number 1. Now, the wheels are in motion for the Affordable Care Act, and there's been a ton of work done across the country on value-based purchasing, Impact Act, bundled payments, etc. We do not know what will, I'm an independent, I'm a half glass full type of gal, and there's opportunity with either administration. That's how I feel. That's just my DNA. Having said that, if there's a repeal, if the government changes their mind, then we've learned a lot and we have to toggle and be adaptable. Now again, do not know how imminent change would be. I just don't know. But the piece is that the cost per Medicare Part A beneficiary is the root cause of payment reform. And the dichotomy of patient expenses varying facility to facility is what teed it up for the government to say what's going on here. Now, I also think, though, as a cost-based direct care clinician, I understand the value of therapy in a nursing facility. I understand OBRA 87. And I think that one has to take a really good look at what is needed by the patient and objectively look at, is there value to this? So the intent of the Triple Aim Affordable Care Act, Impact Act, value-based purchasing is to improve quality, decrease cost. So while you're doing this, I am also an advocate for that $500 a day in the SNF setting is a far better deal than $2,500 to $5,000 a day in the acute care. I say this because if you think or you're panicking, you should not. There is a skill set in the SNF sector that is unseen by any other continuum of care. Do not underestimate your value, and do not underestimate the cost savings by virtue of a patient going into your setting. Now, you may look a little different. You might look a little different. Your physical plant may change, i.e. via the conditions of requirements of participation, but your skill set and services will not. And what I mean by that is they need clinicians that understand how to treat the aging population. It's complicated. And people are living longer, and there's about 20 million of those baby boomers that are merging in 2020 into the age that they would be in a skilled nursing facility. Now, the skilled nursing facility may not have 3 beds and 3 beds to a bathroom. It might be private. It might be built after 1970, but there is definitely a product line / need and demand for said services. So, however, the reason for this first slide is that, look, it's all about what does it cost. Now, the second thing I want to throw at you, and this is a major nugget, when I treated, I have 12 seconds, when I treated, we never discriminated based on payer sources. When you review the regulations that were recently came out, it talks over and over again about non-discriminatory. So if I have a managed care company that is taking over a fee-for-service patient, and it says you only can treat them for 2 weeks, think through this for a minute. I am discriminating, okay? In other words, if the clinician's judgment, skills, knowledge, and judgment do not derive the treatment plan. There is a fundamental issue with that payment source. So I'm just saying that out loud. I think that's going to be a big area. Some more details for you. There's some links for you. Okay, so closing thoughts. Well, yes, always get back to basics. I stopped 7 years ago talking about the 4 pillars of nursing documentation and skilled care because I was droning on in my own head on how boring it was and how everyone must know this. Well, guess what? You have turnover, you have change. Always go back to basics. Look at implementing your compliance and your QAPI programs. They inherently, baking them into your day-to-day operations will inherently improve your results and address the metrics the government is expecting you to look at. I think that there's major viability in skilled nursing facilities. I think that you just have to sit back and breathe, distill, synthesize, pick up the hood, look in your medical records. That's what we do. We get under the hood and we find you don't know what you don't know, and apply principles, chunk it on a day-to-day basis, and do not become overwhelmed. Let me just say this last comment. I truly believe that the United States of America is overwhelmed. Hear me out. And not for any other reason than social media, emails 24/7, technology is just controlling our lives. And again, I'm a product of that because I have to get to the white and keep up, meaning the white that I can see all my emails in one glance. People are not the same. They're on edge. Just don't be stressed. Breathe and pull your group together and maybe have some sustenance like chocolate chip cookies and manage your day-to-day, get a plan in place, and you are going to be just fine. So I'm going to pause now because my time is up. Thank you so much for joining us today.
Thank you so much, Chris. I'm actually going to pass it over to one of our internal folks, Misty Olson. Misty, are you ready to present? Can I make you a presenter?
I am.
All right, and we're going to show a little bit of product that can help you keep up with some of this stuff, and then we'll circle back to a few questions. So take it away, Misty.
Can you see my screen okay?
I can indeed.
All right, fantastic. Hello, everyone. If you're like me, anytime one of these final rules come out, your head is spinning just because of so many changes. And you're expected to keep up with all of these things and do the readings, but it's almost impossible to do. Here at Wolters Kluwer, we have quite a few tools that would be able to help you out, one of which is called our Audit and Revenue Resource Center. What the Audit and Revenue Resource Center contains is over 150 different resources of healthcare information, all consolidated into one platform. So everything from the OIG, CMS, Federal Register, state information, billing information, where from your local coverage determination to your national coverage determination. You've got all of your electronic code book information. We've got your coding clinic, your CPT assistant changes, along with all your other code book guidance. With this product, what I think is very special for each and every one of you is the ease of being able to get alerted on updates that are happening. What we have is a daily newsletter that goes out, and it's called the What's New. And you can tailor this to your needs. So because we have so much information in here, it may not be relevant to you within your job role. So you're able to tailor to just say, I want to see what's going on with CMS, the FDA, OIG, and major issues. You can do that. But one of the advantages that most people find with this product is this browse by subject, and I will show you why. We have taken from everyone who has used the product and done special searches where they go most frequently and what would help them with their specialty areas. And the specialty area of the skilled nursing facilities, we've compiled sort of a quick search for you. Right here, you're going to see your benefit policy manual information, all the subsections that are very specific to skilled nursing. You're going to see your national coverage determination information. You're going to have your code books and guidance for your HCPCS, CPT, and I-9 and I-10. We've also got reimbursement tools and resources. We've got a SNF claim calculator. It's built off the PC Pricer, but it's very it's not broken down to the details that we need right now as far as readmission rates and all of the other things that you're now getting tallied on. We are upgrading it, but it's just a basic calculator, but it still gets you to a roundabout dollar figure. We've also got your OIG resources and your federal regulations along with your quality report and your Part D drug coverage. So at any time, instead of going through CMS and trying to find this publication, and you know that you're looking for payment bans or something like that, or denial of payment, what would be the process? You would be able to quickly click into the document, see that it is when it was issued, when it was when the revision had happened, when it was effective, and we all know that those can be 2 different dates. You will also notice in red that it specifically shows you what the changes are from the previous document to what this document is. And we also have, in case you have to go back in time, a revision history. We're the only ones that have all of this archived information, and even CMS uses us for that specific feature. At the top of the page, you can see some quick explorers that we have, and I'm just going to show you a quick example of one of them. You can put in a code, type in a name, you can type in a set of codes and get some general information from them. And on the screen, or one click away, you're going to find everything to do with this code. Put in the easy one, 71010 is the chest x-ray. You're automatically going to get your APC payment calculation, your RVU payment calculation, your status indicator of active. You're going to get your diagnostic test. You're going to get your status indicator and your APC. But the nice thing is, if you're doing further research into a particular code and you want to get some guidance, if you just click right here, it's going to search those libraries that I told you, those 150 different resources that we have, and let you know that where 71010 was mentioned, here's something for you to need to know about it. So instead of doing multiple searches through several different websites to get this information, right here you've got your PEPR report. Right here you see what the anesthesia CPT crosswalk is. You would also be able to see what your national coding policy is. Anything that's within your HCPCS and CPT code book, CPT assistant archive articles, and CPT changes, all with one click. Because it is web-based, you just have to hit your back button to go back to the previous screen. You'll have your local coverage determinations. You'll have any transmittals concerning that code. You'll also have your code book information. And we not only add in this code book information just what you clicked on as far as it being APC or HCPCS, you would be able to go ahead and just expand some of these right here, and you'll see your radiology procedure guidelines. You'll see any of your procedures that you need. You will also have all of your descriptors that you need, including the clinician and consumer-friendly, citations, code flags, ambulatory, where you just expand. You're not having to go into a different code book to get this information. It's all right here on one screen, and your physician fee information. Anytime you see something highlighted in blue, that's just a hyperlink to go to the information. So if you needed the modifiers, you'd be able to just click on this link and go directly there.
Misty, thank you so much. This was great. It was a really great overview. I think we can squeak in a couple of quick questions, Chris, if you're still available, if you want to squeak over a few minutes. My first favorite is, how do I get a VB calculation t-shirt, which I may or may not have been a serious question, but
Tell him to email me. I'll send him one. That's hysterical. That's hysterical. It was a huge hit at our symposium, and we were just laughing. We did it as a joke. It's so funny. Yeah, we have some here.
That's great. So a question right off top, I think it's a pretty easy one to answer. Sarah asked, this does not apply to critical access hospital swing beds, correct?
Correct.
Okay, so that was an easy one right off the top of my head. And then Denise asked, is the 2% penalty for SNF QRP in addition to the 2% for VBP? In essence, could a home have a 4% penalty?
Excellent. Yes, it is. Excellent question.
Right. Okay, so yeah, you are looking at a 4% penalty. That is a good question. Sydney asked, what is the definition of a potentially preventable admission?
Okay, well, that's what they're trying to define, and we should know probably within, I don't know if it's been announced, but on slide, let me pull this, can I get back to the slides, or no, I'm not sure if I have control over it, but if you go, who asked the question, Sydney?
Here you go, Sydney, yeah.
So let me go to slide, wait, see if she can move it back. I'm going to go back.
There you go.
This is the bone of contention, by the way. This is, it's the one that had like infections, chronic decisions. Okay, let me go back here. Oh, up in the front. Sorry about that. Here we go. So we don't know. The definition will come out, but the concept is that it'll have something to do with, let me pull up the slide.
I asked a hard question, apparently.
Oh, no, well,
we'll get back.
Yeah. PPR, preventable, potentially preventable readmission measures. There'll be slide 62. 4 clinical groupings: chronic conditions, infections, unplanned events, and injury prevention. So, in other words, if I'm going to pull out the final rule that I have right in front of me, and it's under performance standards, and I'm pulling up the rule right now, and give me 1 second. It's going to be on page. It starts on page 141, and it will start describing the preventable, the potentially preventable. It's number 3 of 3 metrics, and basically what they're saying is that they don't have what it is yet, but the areas would be in those 4 areas. And I have page 142, and they're looking for a 2-year trial period. So I'm just going through it right here. And again, if you've ever read a final rule, there's a lot of dialogue and opinions because they like to put in the commentary from the public. The real issue here is that what is the definition, and they can tell you with 61 days prior to implementing it. Again, we don't know the definition as of right now. It's under discussion.
All right. Well, I think we need to wrap it up. I thank you so much again, Chris and Missy. Both give excellent presentations today, but Chris, as always, a high-speed race through everything we need to know. So thank you so much again, and thank you all for coming. We're going to end the webinar right now, but look with it for your follow-up email within 48 hours. Thanks very much, everybody.